Okay, good evening and a warm welcome to all the delegates, participants and members in this webinar series, series 1 and 107 number webinar. Today we have Dr. Itesh Vijay Kumar Khatwani. And the topic of today's webinar is the role of anti-epidermal growth factor receptor monoclonal antibodies in head and neck cancer, the evolving trends. Myself, Dr. Rajat Kumar Shaha, I will be moderating today's session, and it is a proud privilege for me to give a brief introduction about Dr. Itesh Vijay Kumar Khatwani. So he's the consultant medical oncologist and hematologist at Oncovin Cancer Center and Narayana Hospital, Ahmedabad. And he's a super specialist in the field of oncology and completed DM from Gujarat Cancer and Research Institute, Ahmedabad. And he's an expert in chemotherapy, targeted therapy, hormonal therapy, and immunotherapy. And he has vast experience in treating patients of oncology and hemato-oncology, including leukemia, lymphoma, and myeloma, to name a few. And he has published articles in various national and international journals, and also presented and has numerous presentations in the national and international conference forums. And he has also been the co-investigator in a clinical trial conducted in Gujarat Cancer and Research Institute. So with that brief introduction, we invite Dr. Itesh Vijay Kumar Khatwani to go ahead with your deliberation and enlighten us on this interesting topic. Over to you, sir.
Thank you, Dr. Rajat, sir, for the kind introduction. Am I audible clearly?
Yes.
Good evening, everyone. Just try to share my slides from here, sir.
Yeah.
Are my slides visible?
Yes.
Good evening, everyone. So today we are going to talk about role of anti-epidermal growth factor receptor monoclonal antibodies in locally advanced head and neck cancer. We know that the treatment of cancer, specifically head and neck cancer, is evolutionized with the advent of targeted therapy and immunotherapy. And we have new and new molecules coming day by day because the treatment with standard chemotherapy and radiation or surgery is not that optimal, and still many patients do relapse after treatment in locally advanced head and neck cancer. So in next 20 to 30 minutes, we will have discussion about EGFR overexpression in head and neck cancer, the prognosis of patients with EGFR overexpression, what are the molecules in anti-EGFR therapies we can use beyond standard chemo radiation, with special focus on nemotuzumab in locally advanced head and neck cancer, and also its comparison with other approved anti-EGFR therapies. We talk about head and neck cancer, we can say that India is almost the factory of production of head and neck cancer patients. So worldwide, the most number of head and neck cancer patients are seen in India because of tobacco consumption, specifically in areas of Gujarat and Maharashtra, which is quite common. We know that head and neck cancer are usually aggressive cancers. They behave aggressively because most of the patients do be present to us in advanced stage, and they also have tendency of tobacco and other addictions, so they also have chance of second malignancies. There is high EGFR overexpression in many patients, and we will see in further slides that how EGFR overexpression has poor prognosis and how we can choose a definitive plan in such patients. We also categorize head and neck cancer patients broadly into HPV, that is human papilloma virus positive, versus HPV negative patients, because these HPV positivity and negativity do have some prognostic effects. And at last, we also have a discussion about the therapies beyond standard chemotherapy and radiation. when surgery is not possible. So talking about EGFR, EGFR is epidermal growth factor receptor. EGFR overexpression is found in many head and neck cancer patients. EGFR is basically a type of oncogene. So if EGFR is overexpressed, then there is more chances of tumor proliferation, increased tumor angiogenesis, decreased apoptosis, which leads to increased chances of metastasis and progression of the disease. So ultimately, in nutshell, EGFR overexpression is a marker of aggressive disease because it might hamper the treatment response. It might lead to disease progression more rapidly, and such patients therefore have poor prognosis. If we talk about the standard chemoradiation, which is given in those patients of head and neck cancer who have locally advanced disease and those who are not amenable to surgery, or when we are planning for organ preservation, like diseases involving larynx or voice box, where we want to preserve the voice box and we want to go for definitive chemoradiation. We can see that if we give radiation alone in these patients, then disease-free survival is almost around 1 year. With addition of chemotherapy, the lifespan increases to 19 to 24 months with various regimens, and standard regimen used is cisplatin. So lifespan can be disease-free survival can be increased from 1 year to 2 years with addition of radiation. But still, if we talk about curative setting, then hardly 40 to 50% patients are getting long-term survival or cure, and still there is an unmet need of improving the survival of at least 50 to 60% of the patients. So here we can see that with chemoradiation, the 5-year logarithmal control, that local disease is not there in around 50% of the patients if we combine chemotherapy and radiation. However, if we give only radiation, then only 32% of the patients will have local disease control. To talk about disease, overall disease-free survival, local plus systemic, then around 60% of the patients do progress after chemoradiation, either locally or at distal site, like lung, liver, or bones. But with radiation, 75% of the patients do progress. So definitely adding chemotherapy adds to the survival. But again, these 60% of the patients can have benefit if we can add something, we can add a drug which adds more to the survival. If you talk about overall survival, which is the bottom line for all the cancer patients, with chemoradiation in locally advanced head and neck cancer, around 56% of the patients have 5-year OS. That is 5 year. At the end of 5 years of treatment, around 56% of the patients are surviving after chemoradiation. So probably they are cured, you can say. Most probably they are cured, 99% you can say. Because recurrences chances are very less after 5 years. Still, there is unmet need of improvement in rest 44% of the patients. This is the data which shows that addition of chemotherapy compared to radiation, is there any difference in overall survival? So these are the various studies which have been carried in last 20-25 years, and we can say this last column that yes, most of the studies say that yes, there is advantage of survival when we add chemotherapy to radiation. Like EORTC trial at 2004 shows that 53% survival with chemoradiation as compared to RT alone. Most of the trials say yes. Couple of trials say there is no significant difference in overall survival, but still disease-free survival is improved with chemoradiation. One study says, another study says that there are chances of larynx preservation, though there is no improvement in overall survival with chemoradiation. So majority of the studies do believe that there is significant overall survival benefit in the tune of 10 to 20% when we add chemotherapy to radiation. One thing is clear that in locally advanced disease, we need multi-modality treatment rather than giving only radiation or only chemotherapy. We need to combine them, and probably we need to give them concurrently. If we talk about newer drugs or other drugs, many drugs have been tried. Apart from standard chemotherapy like cisplatin or carboplatin, many other drugs have been tried in locally advanced head and neck cancer. We can see the molecular targets available like EGFR, HER2, vascular endothelial growth factor receptor, IGF, MET, mTOR, and many more. These are the all receptors which have been tried to be targeted with various drugs. We have use cetuximab, panitumumab, bevacizumab, which is VEGF inhibitor. But no need to go in details of all these drugs because most of these drugs have not been able to improve survival or give benefit to the patients apart from chemoradiation, except cetuximab, I can say in metastatic setting has found benefit, and nimotuzumab definitely in locally advanced disease has found benefit, which we'll discuss in further slides. And this last column shows anti-PD-1 antibodies, which is immunotherapy. This has been approved for metastatic or recurrent disease, but again in concurrent chemoradiation setting, as of now, there is no benefit of adding immunotherapy to such patients with chemoradiation. So, as we discussed that altered radiation schedules, addition of other chemotherapeutic drugs have failed to improve outcomes apart from standard chemoradiation, even neoadjuvant or adjuvant chemotherapy, that is chemotherapy before or after radiation has also been tried, but it has been in vain. It has not been able to improve outcomes in such people. If we talk about EGFR overexpression, we have already seen that it offers poor prognosis when there is EGFR overexpression. It is found in majority of the patients. Addition of cetuximab has been tried with radiation. It has improved survival to some extent in selected patients. We can see in palliative chemotherapy, definitely cetuximab addition to chemotherapy has improved overall survival. But in patients with radiation, it has improved survival only in selected subsets. If we talk about standard subsets, this was RTOG study in which locally advanced head and neck cancer patients of stage 3 and stage 4 were randomized to cetuximab plus standard chemoradiation versus standard cisplatin plus radiation in those patients who were not amenable to surgery or those who wanted to go for organ preservation. We can see that the survival curves are not falling apart, whether it is PFS, that is progression-free survival, or whether it is overall survival. There is hardly any difference in the survival, and we can see that p-value is not significant in both of the arms. So we can conclude from this study that in majority of the patients, addition of cetuximab to CTRT does not add much to the survival in locally advanced head and neck cancer, though it has proven benefit in metastatic setting, but locally advanced setting, specifically when patient is eligible for cisplatin, cetuximab is not much useful. If we talk about other anti-EGFR monoclonal antibodies, we can see that as we go down, the survival goes on increasing. If we talk about the standard of care, cisplatin plus chemoradiation, median overall survival is around 18 months. Addition of cetuximab, we have seen that there is no significant survival benefit if patient is cisplatin eligible. But if we talk about MAbs, that is nimotuzumab, MAbs plus radiation increases the overall survival to 45 months. It is whooping around 2.5 times increase in survival with addition of this drug without chemotherapy. And if we add that chemotherapy to nimotuzumab in fit patients, then the median survival goes to around 5 years. So we can see that almost there is tripling of overall survival with addition of nimotuzumab, which is a wonderful drug for such patients. So probably the unmet need has now been found in majority of the patients where we can use MAbs in eligible patients, which we'll discuss in further slides. If we talk about EGFR expression, we see that 80 to 100% of the patients with head and neck cancer have EGFR overexpression, and in various studies, it has been found that EGFR overexpression has poor prognosis. These patients had decreased disease-free survival and decreased overall survival. Also, in pancreatic and bladder cancer, it was found that they have poor prognosis. And there are many number of studies, and around 82% of the patients have associated decreased survival because of EGFR overexpression in head and neck cancer, and also in other cancers like breast, colorectal, and esophagus. If we talk about the mechanism of action, then cetuximab and panitumumab are other EGFR antibodies, of which cetuximab is approved in metastatic setting. We discussed. Panitumumab is not approved in head and neck cancer. It is used in colorectal cancer. But if we talk about the mechanism of action, cetuximab and PMAb add to the monovalent site of EGFR receptor and have consistent binding independent at the level of EGFR expression. However, nimotuzumab has bivalent binding to EGFR, so its accumulation is significantly affected by increasing EGFR concentrations. So patients with more EGFR expression, have more concentration of BioMAb, and probably they might respond better and might overcome the negative benefit of EGFR overexpression. Also, skin cells have EGFR expression, but it is in low percentage. So nematocyte binding to skin is very less. However, cetuximab specifically has more binding to skin, so it leads to skin toxicity and dermatological side effects, which is very less often seen with nematocyte. So it has two benefits: bivalent binding and decreased skin bindings, which also decreases the side effects when we use nematocyte. Now coming to the trial data, we are saying that nematocyte has several benefits. On which basis it is being recommended? So we have many number of studies, and we will discuss few important landmark studies which led to approval of nematocyte in our clinical practice. You can see that this is a phase 2B study, 5-year study. So we have a 5-year long data in inoperable advanced head and neck cancer. That is best study, BioMAb efficacy and safety trial. If we talk about the overall response rate of CT-RT with nematocyte, it is around 100% at the end of therapy. While with cisplatin, that is chemoradiation, the overall response rate is around 70%. If we talk about overall response rate at 6 months of treatment, still 76% of the patients had response with nematocyte arm, while only 37%, that is almost half of the patients had response to standard CT-RT arm, and with p-value significant. So we can say that significant response rates are achieved, and increase in response rate is persistent when we add nematocyte to chemoradiation. If we talk about 5-year survival, then definitely nematocyte arm wins over other arms, because the 5-year survival with nematocyte arm is around 47.8%, and with CT-RT arm it is around 26%, and with RT nematocyte it is around 39%. So this proves that there is significant PFS, that is progression-free survival benefit, when we use nematocyte in addition to standard chemoradiation. If we talk about median overall survival, we can see the curves. They are moving wide apart. With nematocyte and CT-RT, 5-year survival rate is around 57%. And median overall survival has been not reached at 5 years. So we can say that majority of the patients do live for more than 5 years when we offer them nematocyte, as compared to only 22 months with standard chemoradiation, and p-value is significant in both the arms. So we can see almost 2.5 to 3 times survival when we give nematocyte to the patients. Again, this was a phase 2B study. So further to confirm this, a phase 3 trial was initiated when we compared nematocyte plus CT-RT versus CT-RT. And as we see that 536 patients of locally advanced head and neck cancer, non-metastatic, specifically those who are eligible for CT-RT, like pharynx, oropharynx, apopharynx, larynx, or inoperable oral cavity cancers, were randomized in 1:1 fashion to BioMAb plus CT-RT. The standard dose of BioMAb is 200 mg given every weekly with CT-RT, and cisplatin 30 mg per meter square weekly with standard dose of radiation, that is 70 gray. Nasopharyngeal cancers were excluded in this study. We can see that both the arms' baseline characteristics were matching, and the most important curves, we can see that progression-free survival is again at 2 years with nematocyte. It is significantly improved, around 12% improvement in 2 years PFS or DFS we can see. If we talk about locoregional control, again 10% improvement in 2-year locoregional control with significant p-value. And the most important bottom line is survival. Overall survival we can see that is slightly better with nematocyte arm, and the curves have started to move wide apart, and probably this with long-term data, this difference might improve, as we have seen with previous study. And the most important thing, this was the trial from TMH, Tata Memorial Hospital. So the bulk of the patients and the quality of the trials performed is TMH is tremendous, and they are very meticulous about the trial data. So this is the data which we should definitely rely upon. Again, if we talk about the subgroup analysis, we already discussed that we have HPV positive and HPV negative oropharyngeal cancers. So we have seen that the survival benefit was marginally increased in nematocyte arm. So we have to find out that in which subsets of patient it is more useful. So if you see HPV negative oropharyngeal cancers in this study, 187 patients were HPV negative of the 534 patients, and 91 patients of them were in chemoradiation arm, and 96 patients received nimetuzumab. If we see the evaluation of HPV negative patients, then we can see the significant survival benefit. Median PFS is almost tripled in nimetuzumab arm from around 13 to 36 months. Again, if we see locoregional control, that is very much improved in nimetuzumab arm. And coming to the bottom line, median overall survival again is almost double. 19 months in chemoradiation arm, as we discussed in previous studies, but in nimetuzumab arm, it reaches to around 36 months. So p-value again is significant. In HPV negative patients, we have seen that median OS is improved quite dramatically as compared to overall population. So probably these are the patients whom definitely we should think of using nimetuzumab. And in Indian practice, we have found that HPV negative population is much more common because most of the patients have exposure to tobacco as compared to Western culture where HPV positive infective head and neck squamous cell carcinoma is more common. Again, the most important thing is that what is the quality of life or toxicity when we give additional drug to the patients. So quality of life was also very well studied in these trials, and we have various parameters to compare like global health status, difficulty in swallowing, coughing, physical function, pain, as well as dryness of mouth, which is found because of chemoradiation. So we can see that in all the parameters, both the arms go almost parallel to parallel. Whether we give nimetuzumab, that is the red curve, or we don't give it. So most of the patients have very good preserved quality of life, even despite of addition of nimetuzumab, with significant improvement in survival. So the bottom line is addition of nimetuzumab does not increase the toxicity and it maintains the quality of life. If we talk about nasopharyngeal cancer, because these patients were excluded in most of the previous studies, we have a study of nasopharyngeal cancer stage 3 and stage 4, where nimetuzumab with CTRT were compared in a randomized 3:1 manner, and primary endpoint was 5-year overall survival. We see the 5-year curves. 5-year overall survival in nimetuzumab arm again was around 77%, because we know that nasopharyngeal is again a good biology relatively compared to other head and neck subsites, and it was around 64% in CTRT arm. So there is almost 2.5% absolute 5-year survival benefit, which is very, very significant for head and neck cancer patients. So we can, based on this data, the National Cancer Grid and Indian Journal of Cancer consensus guidelines have also incorporated nimetuzumab in locally advanced head and neck cancer in addition to standard chemo radiation. So in conclusion, I would like to say that head and neck cancer is our own problem in India, because Indian patients and Indian biology is obviously different from Western world. We know the risk factors and are totally different in Indian subset as compared to Western population. Other anti-EGFR antibodies have not yet shown benefits in locally advanced setting. Nimetuzumab plus CTRT we have discussed has shown significant improved overall outcomes in locally advanced head and neck cancer in the form of improved overall survival, improved locoregional control, as well as improved disease-free survival without any negative impact in the quality of life, which is again important. Thank you very much. I would like to take questions if any.
Thank you, Dr. Itesh, for this splendid presentation and finishing much before time. And the way you discussed about nimetuzumab and the evolving trends, and for going beyond the chemotherapy and radiotherapy, and targeting EGFR in head and neck cancer, and the long-term survival which is increased in chemoradiation and compared to radiation, and when we are using this anti-EGFR agents, and Also, you have discussed the research studies for improving the outcomes and also the survival rates with the chemoradiotherapy with or without the anti-EGFR agents. And you also discussed the monovalent binding versus the bivalent binding of nemotuzumab, which is a bivalent binding. So the incidence and prevalence of lower side effects compared to the agents which have monovalent binding. And also you discussed about the best study and also the research outcomes and progression-free survival at 5 years, and also the 5-year survival rate, which is positively affected with nemotuzumab, and the effect of nemotuzumab with the concurrent radiotherapy and the chemoradiotherapy, and also the significant p-value in the statistical data, which is very important, which is very significant. And also lastly, the quality of life, which is very positively affected with the use of nemotuzumab. So if we have any questions from the participants and delegates who are attending, so we can take the questions. I think the chat box, we don't have any questions in the chat box, but we can take on the questions if anyone wants to ask. Okay, so I think we don't have any questions. So thank you so much, Dr. Itesh. And
Thank you, Dr.
On behalf of the Association of Environment and Occupational Health Delhi branch, I'd like to thank you for coming over on this virtual platform and addressing us and enlightening us on this evolving trends of this anti-EGFR and in head and neck cancer and monoclonal antibodies and in head and neck cancer. And we look forward to have more of these sessions with you and a long-term association as always. Thank you so much.
Thank you, sir. Thank you. It was a pleasure having you. Thank you. Good day.
Thank you. Thanks.
Bye.